Welcome to the External Medicine Podcast. We are here with Dr. Adam J. Brown of the Cleveland Clinic. Dr. Brown is the author of the book Rheumatology Made Ridiculously Simple, as well as the host of the podcast Rheuminations, which focuses on autoimmunity, rare diseases, and the history of medicine. Adam, welcome to the show.
Hey, thanks so much for having me. I'm happy to be here.
Before we get started, do you have any financial disclosures?
Yes, I consult for the pharmaceutical company Amgen. They pay me to try and figure out how to make the complement system understandable. So I like making complex things understandable. So that's what I do.
Let's get into some background questions for the people in our audience who are not of a medical background. How do you describe exactly what a rheumatologist is and what one does?
So I think rheumatology, I describe it in the way that we're the people when the immune system is acting awry, we're involved. So the immune system, is supposed to be fighting off bacteria and viruses and keeping you safe, but for reasons we don't know, for the vast majority of disease, we don't know why this happens. For some reason, the immune system misfires, and it's supposed to be fighting off bacteria and viruses, and misfires and attacks your joints, for example, attacks your lungs, attacks your kidneys, attacks any body part possible. And it can manifest in a very wide pattern of diseases. And a rheumatologist is there to kind of try and help, A, diagnose it, figure out what it is, see if the immune system really is involved in causing the problems, and B, trying to figure out a way to tap it down. And we try and figure out a way to tap it down without massively immunosuppressing the patient. So we have kind of a cadre of medications now at our disposals that can really make a huge difference in the vast majority of our conditions that we treat nowadays. So it's an exciting field because we're getting a better understanding of these immunopathogenesis and more armamentarium to our medication options every year. So long story short, we're involved when the immune system is misbehaving, and we try and figure out a way to kind of calm it down.
Is there one overarching framework for rheumatology where you can fit different diseases into it? Or does each disease or disease cluster kind of have its own explanation, mental map?
Yeah, that's a good question. I have never been asked it that way. Let me think about it. I think that, when we like, for example, when the lungs involved, that gives me, X, Y, A, B, C, D, E, F, as part of autoimmune possibilities that can do that. If the kidneys are involved, that gives me A, B, C, D, E, F, G, and some of those overlap and some of them don't. So it's really pattern recognition, as you see, the kidneys are involved, the lungs are involved, and then these joints are involved. And, in rheumatologists, we always get made fun of. We always talk about, well, what's the pinky doing, but it's like, in reality, it really makes a difference because like certain diseases like certain anatomical areas. And one thing I think to know up front to get rid of some of the mystery of rheumatology is we have no idea why that is. So a big fundamental aspect of rheumatology where we recognize these patterns, like the rheumatoid arthritis likes the metacarpal phalangeal joints, and the psoriatic arthritis likes the distal interphalangeal joints. We have no idea why that is. So it's something we recognize, like, MCPs are involved is maybe more likely rheumatoid arthritis, or the DIPs are involved is more likely psoriatic arthritis. But if you ask us why that is, we still don't know. So it kind of eludes the huge mysteries of this condition, is we can recognize the diseases because of the pattern, but we don't know why that is. So it's like, so to answer your question, it's a blueprint based on pattern of joints involved, movement of joints, like the whole migratory pattern people always talk about, which is overall pretty rare, and then organ involvement. For some reason, most of our diseases, for example, don't like touching the liver. We don't know why. They can do everything. I mean, autoimmune hepatitis is obviously its own entity, but most of our diseases like lupus and small vessel vasculitis don't seem to bother the liver very much, and that's a big mystery. We don't know why that is. So to answer your question, it's just like a lot of these conditions have an overlap, and just trying to pin down, okay, the joints are involved, the lungs are involved, kidneys aren't involved. Could they be involved? Look for these things that. I don't know if I answered your questions very well, but it's just kind of trying to pinpoint what objective changes do you have, and then try and figure out what diseases can fit into that disease.
When you talk about the role of rheumatology, you brought up sort of trying to understand the immune system, kind of alluding to autoimmunity. There is another specialty that also deals with autoimmunity, the allergist. So when you look at the 4 types of hypersensitivity that I was required to memorize for step 1 and 2, but I've totally forgotten now. Type 1 is treated by an allergist, but the other 3 types of hypersensitivity reactions are treated by somebody in the rheumatology department. Do you know why that is?
Yeah, great question. So yeah, allergy is pretty different. Well, the term we kind of throw out is like, oh, allergy is kind of IgE dependent, and rheumatology is not IgE dependent. It's probably a lot more complicated than that. But yeah, we think of like allergy is kind of reactive to something, an allergen, right? Whereas autoimmunity is, we don't know what it's reacting to for the most part. But that's kind of a simplistic way to say it. That's probably a much more elegant way to describe the differences between the two. But they're different diseases because they behave differently to different therapeutics, but they both respond pretty well to steroids, as so many things do in medicine, basically. But they, looking historically why certain diseases are treated by certain specialties, it would have to go back a long time how to figure that out. For example, people ask me, oh, do you treat autoimmunity? You must treat multiple sclerosis. And oh, no, it's autoimmune disease, but neurology treats it, and now it's immunoneurology. So everything's getting very compartmentalized and specialized. And then, for example, what I mentioned before is autoimmune hepatitis. That's not treated by rheumatologists. It's treated by hepatologists. So you could easily ask, why do all these things get kind of compartmentalized in different things? And it's probably just historic, why those things happen. That neurologists were the first ones diagnosing MS, and they kind of got used to when the treatment was very, very limited, they got used to giving steroids, for example. But then, as these disease processes start delineating and we get better understanding of them, they get more complicated, and then people start specializing in them. And then neurologists took it, and then hepatology took autoimmune hepatitis, and rheumatology has most autoimmunity, but again, sometimes certain specialties pick them. But I think allergy is genuinely different. But I think that to answer the question historically, why certain specialties pick different diseases, it's just probably historical. Something happened in the 60s or 70s when things were getting split up.
Well, that's a great segue. Can you talk to us about how the field of rheumatology developed? So, for example, I think in like the 50s and 60s, nephrology didn't exist as a discrete entity within medicine. It was fluid and electrolytes. And then over time, it became, the kidney doctors. So I'm just sort of curious, you've done a lot of deep dives into history and rheumatology. Yeah. So where does the field come from? How does it begin?
Yes, similar to nephrology, it evolved slowly. So I think that kind of alludes to, we didn't know what autoimmunity was until not that long ago, right? In the early 20th century, basically. So I think that let's give an example of rheumatoid arthritis. Rheumatoid arthritis was probably first described in 1800, where it's like has a case where there's like, that sounds like rheumatoid arthritis, because these old descriptions, their complete mindset was totally different than ours, so it's hard to recognize some of the disease entities. But there's a decent description from 1800 of a patient that sounded like they had rheumatoid arthritis. So up until World War I into World War II, we thought it was an infectious disease. So they had no idea it was really an autoimmune disease. People knew about autoimmunity, or horror autotoxicus, as they called it. But they didn't really say, that rheumatoid arthritis was an autoimmune disease. On synovial biopsies, there was lots and lots of inflammation in some of the synovial lining of these patients who had it. But again, sometimes those biopsies may have been contaminated and they had streptococcus. I said, oh my God, is this, streptococcus doing this? So that even kind of alluded to some of the original drugs that were developed for this, for treating rheumatoid arthritis. For example, sulfasalazine. So sulfasalazine is a drug we use in rheumatology, and it was designed because sulfa is the first antibiotic. And they put a moiety basically, and they were giving sulfasalazine orally, but they didn't think it had good penetration into the joints. So they put this other moiety to it that allowed better penetration into the joints. So it's called sulfasalazine. So they gave this to patients with rheumatoid arthritis, thinking they're treating the actual infection, when in reality they're actually causing some degree of immunosuppression, which is actually probably what helps them, although it's not totally clear why sulfasalazine works. But it was that kind of leads to why it was thought for decades to be an infectious disease, and it took a long time to really establish itself as a true autoimmune disease. So we're talking like 50s and 60s of this slow understanding of some immune pathogenesis, primarily not driven by infection, and it probably had a lot to do with us getting better and better at treating infections. So 40s, 50s, we start getting more and more antibiotics. We got penicillins, we got tetracyclines, and we have ability to treat infections. But these patients with rheumatoid don't do any better, on these other antibiotics. So it starts saying, okay, there's probably not some primary infection driving this. So that was kind of the big flip when we started actually making it its own specialty, is the recognition over decades that it's an own entity, which happened very, very slowly. And then when it finally was established, we didn't know what to do about it. So we had steroids since the 40s. We recognized that would help people briefly. And then we caused lots of issues with, cushingoid. We caused lots of issues with major infections in these patients. So we realized it wasn't a very good long-term option for most of our diseases. But then we look at methotrexate. So methotrexate is kind of this drug that we've had for decades and decades. It was discovered in 1944, mid-40s, and it was used to treat leukemia in children. So it was used at very high doses to try and save these kids' life. And understandably, it had a huge, massive amount of side effects: hair loss, oral ulcers, major infections, and could cause cytopenias that can kill somebody. So it was very like, people were like, okay, this is a really serious drug. So we recognized that it probably would, as it dawned on people that these diseases were too much immune system in rheumatoid arthritis, for example, we said, wait a minute, we have these other drugs that the oncology world is using, and they cause immunosuppression. It's like their side effect. That was the primary goal of that medication, but it does cause severe immunosuppression. Why don't we use these drugs for the people with rheumatoid arthritis? And as you can imagine, people are like, oh my God, that sounds like a disaster, because we recognize the drug itself could kill the people. They can be very, very sick. So, but rheumatologists started, as you started making us into a specialty, that's all we were studying, started realizing that if you give tiny doses of methotrexate. So I would give an example: if your immune system is too high, and we want to kind of normalize it, or just a little bit low, we can give like a fraction of the dose of methotrexate. Kind of, I would say, rheumatologists sprinkle methotrexate, and oncologists douse you in it. So it gave way to that realization that you can give tiny doses of methotrexate, and you will immunosuppress the patient. I'm not arguing that, but you don't get the massive other problems with the hair falling out, the oral ulcers, the severe infections that you get when you're on the high dose. And that really kind of opened the door for rheumatology as this kind of specialty. They said, oh my God, we got these medications that work, and we can give them in a safe way, and it's kind of a specialized way, because we learned that with methotrexate, you kind of have to monitor for toxicity, you have to get liver enzymes, you have to kind of monitor for cytopenias. So it started kind of niching itself out in the 70s and 80s, when you actually had to like gain the special knowledge to be able to use these medications like oncologists do, but to a much lower amount. So there's not like a aha moment with rheumatology in terms of when it was found like a stamp, and different countries did it at different times, where they had like American College of Rheumatology versus the British College of Rheumatology, et cetera. But I think it had a lot to do with that the 20th century, kind of that slow realization that these aren't infectious diseases. They're actually, the immune system gone awry. Basically, the immune system driving this. We don't know why. In 2023, we still don't know why this happens. But we could treat it a whole lot better than we used to. That's for sure.
I have a little bit of an aside on giving medications that counterintuitively make patients better. So with methotrexate, oh no, you don't want to give an immunosuppressant to someone who has this presumably infectious disease. Right. Reminds me a little bit about the some of the early trials with steroids and COVID. There was a lot of concern up front. You don't want to give somebody with an infectious disease a steroid, because that will, knock down their immune system, and then bad things will happen. And then in the end, steroids actually surprisingly did okay.
I'm glad you brought that up. Yeah, so I have a big interest in steroids and infections. So, looking back at, I can argue clearly that there's more data showing the steroids are probably safe, either to help or don't do anything in the setting of active infection, especially as long as the active infection is being treated. Okay. So people, if you watch movies like House or something like that, they're going to say, well, should we give them steroids or should we give them antibiotics? Like, well, if you're wrong and you're giving steroids and they're sick or they have infection, you're going to kill the patient, right? But in reality, as long as the infection is being treated and recognized, steroids may have a role in certain infections. So back in the day, when steroids were discovered, they actually did trials on various amounts of different infections and just gave steroids without antibiotics. And from this very early literature, it showed pretty overwhelmingly by the 1970s that steroids probably helped a lot of different like URIs and various, probably viral infections. And it's alluding to that maybe they weren't as, a really bad idea as we thought. But then we started getting kind of better controlled trials, like sepsis was a big one. So lots of big trials looking at giving steroids and setting infection. And at first in the 80s and 90s, it was kind of all over the place. They seemed like they were probably helpful. And then in the I think 90s, they got the one where they gave a gram. They gave a huge whopping dose of steroid, and it probably made the patients a little bit worse. They kind of put the brakes on giving steroids in the setting of active septic shock. And then, but then in the 2000s, trials were done bigger and bigger, and actually showed they probably help. And this data was pretty profound. They had prior to initiating the trials, they gave gorilla, some sort of ape. They injected E. coli into these apes. They gave either antibiotics by itself, antibiotics plus steroids, or nothing. And not surprisingly, all the apes that got nothing died. All the apes that got in E. coli plus antibiotics died. The only ones that survived were the apes that got E. coli antibiotics plus steroids. It wasn't subtle. It was like a dramatic. And wow, that study kind of launched the human trials that weren't as amazing. And again, those trials in septic shock are difficult because they have, in the controlled setting, exactly when that ape got the E. coli, right? And humans, by the time they get to the ER, the ICU, who knows how long they've been sick beforehand. One of the big arguments, they have, it's too the time you got the steroids in them. But the steroid, but long story short, we have these patients in septic shock from bacteremia, and you're giving them steroids, right? So it's this notion that their steroids are really, really bad idea probably isn't true. Again, as long as the infection is known, it's undoubtedly people on long-term steroids get infections more. So that's not a question. So people on steroids it's not good because you have a high risk of developing infection, have a worse outcome. But in the setting of an active infection, initiating steroids may not be as bad as people thought. We have clear evidence in meningitis, for example. So you give a rabbit study looked at different types of steroids in literally controlled meningitis, E. coli or step or something, I forgot what bacteria it was, into the spinal cords of rabbits. And again, they gave them antibiotics, or they gave them antibiotics plus methylprednisolone, or they gave them antibiotics plus dexamethasone, so different types of steroid. They measured the pressure in the spinal cord. They measured how the rabbits did. And the ones who got antibiotics plus steroids overall did better. And the ones who got dexamethasone in particular had much less pressure in the brain. So that's why that led to the trial looking at giving Dex in particular, that type of steroid, in patients with meningitis. And then more recently, we have a trial looking at community-acquired pneumonia, getting a patient with pneumonia for whatever organism it was, giving them steroids, and they did much better. They got out of the hospital faster. So long story short, there's more trials clearly demonstrating some efficacy in reducing probably hospital length and possibly mortality in the setting of giving steroids, which kind of led to that big COVID trial, which was the first therapeutic, I think, that showed benefit in patients with COVID. So to me, it wasn't a surprise. We have multiple studies showing, leading up to that over decades, showing active use of steroids could help. And especially in meningitis, it makes sense. We have this massive inflammation caused in a closed space in the brain, and whether it's all the organism or not, or it's your immune system, it's not good to have that much pressure in the brain. So the steroids rapidly reduces that pressure, so it can be seen as a good thing. Even in septic joints, we have a pediatric trial studies showing that kids who got septic joints and they got washout antibiotics, the kids who got oral steroids at the same time had better range of motion. a year later. So they had better range of motion in the joints. So there's a lot of data showing steroids, a safety, may actually be beneficial in the setting of acute infections. So, if you're giving steroids and your patient has endocarditis and you don't know they have endocarditis, that's not good, But if the actual infection is known, and especially if you're treating the infection with antibiotics, the addition of steroids may not be as bad as we thought, and in certain settings may be very beneficial.
Why do you think that is? You'd think that if natural selection was doing what it's supposed to do, or what we suppose that it's supposed to do, that the immune system fights, the infection shows itself, the immune system says, hey, you can't be here, it attacks it. Why is it that the immune system is damaging ourselves in this response? Why wouldn't it know when it's going too far?
Yeah, that's a great question. And there's probably an answer to that, and we kind of got some of that answers from influenza and COVID, where some patients have worse outcomes, and there may be some changes in HLA or how their proteins, how that patient's proteins presents antigen, like viral antigen. And there's a whole lot of genetic variation in the MHC, or the ability for the humans to present antigen, and for reasons that some people have this one presentation where it may make a huge inflammatory response, and in certain infections it's a really bad combination. Like 1918 influenza probably hit people with certain MHC class single nucleotide polymorphisms, and it led to a huge response. So it may have worked out fine otherwise if they hadn't run into the 1918 influenza, which was very, 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 very virulent. But the answer probably lies in bad combination of that their immune system is kind of more primed to erupt, and then that happens to kind of come across, as a very rare infection. Most of these infections aren't common until all of a sudden they are. Like COVID, we hadn't really been exposed to before. But yeah, you're right. In general, it's probably not a good idea to have this robust response, which could actually be harmful to the host. But maybe in certain situations historically, it was protective, right? So maybe certain infections, like the plague, for example, there's really interesting data on how probably the historical evolution and natural selection that occurred during the plague probably selected for possibly autoimmunity in general. And that was, I think I'm going off topic a little bit, but this is interesting, I promise. So they have, so, they're trying to figure out, so the plague, the Black Death, in contrast to COVID, which primarily, kills older individuals, the plague killed everybody. So it killed young, healthy people to the old people. So that probably had a much bigger impact on natural selection, right, than COVID will. And it killed up to, upwards of half the population in certain areas. There's a lot of variation among different cities. So it had a huge impact. So the quick story with that is actually, it's not a quick story, but I promise it's worth it. So one of them is URAP1 and URAP2, which are these genes that I'm going to get to in a minute. So these people were studying the genome of people buried before the 1340s when the plague happened, 1348, 1351. So they looked at skeletons before the plague occurred, and then looked at skeletons that were buried during the plague, and they looked at skeletons buried, tens or hundreds of years later. And I looked at, I think the GWAS studies, genome-wide association studies, where they looked at all the different genes from these skeletons, and they're looking for allelic variation that was kind of expected, like over the course of a century or so, you're expected to have this X amount of changes in certain genes. So that they're looking for is anything that was unintended, like 100 years after the plague, all of a sudden there's this big jump in these polymorphisms in the genes, and they may say, maybe there's something being selected for here. So what they found was they had a high increase in URAP1 and URAP2, which are, again, these genes that are involved in cutting up bacterial antigens, for example, and presenting them. So the antigen presenting cells, where they cut up antigens, and then present them to the T cells, for example, and the T cells recognize it. Oh, great, and they eat it up. So that mutation probably allowed for Yersinia pestis, the causative organism of the causative organism of the Black Death. It allowed to cut up more fine cuts of the Yersinia pestis, so your body recognized Yersinia pestis better, and it allowed you to fight off Yersinia pestis better, and it allowed you to survive. So that was some evolution, but the trick here is ERAF1 and ERAF2 are highly associated with inflammatory bowel disease and spondyloarthritis, psoriatic arthritis, reactive arthritis, inflammatory bowel disease associated arthritis. So it may have primed your immune system to be ready for Yersinia pestis, but in a world where you don't have Yersinia, it may be primed and overshoot, and then all of a sudden you get these inflammatory bowel disease, and you get other spondylitis-related diseases. So microorganisms may have played a huge role in our immune system and selecting for variation in our immune system that may have actually primed for autoimmunity. So, I have a patient who's like saying, hey, I was 45 years old, I was perfectly healthy, and I had no problems, and all of a sudden I have rheumatoid arthritis. Why did I get this? And I'm like, oh, it's probably because of the Black Death. I'm just kidding. It's not that simple, but there's probably some selection that occurred. The more complete story to this is familial Mediterranean fever. So this is really kind of fascinating. So there is familial Mediterranean fever is a disease of the autoinflammatory. So autoinflammatory is this whole category of disease in rheumatology that's not autoimmune. So autoimmune, we typically think of rheumatoid arthritis, lupus, psoriatic arthritis, where you have probably humoral immunity plus innate immunity involved. But in autoinflammatory, it's all driven by the innate immune system. So it's where let's think of if you cut your arm, there's this big immune response to that area. So you kind of turn on the innate immune system, you get these neutrophils and macrophages running into the fight off something, and then you have it turn off. So it's this big on and off switch. It's kind of this clockwork that goes, and you need it to turn on, and you also importantly need it to turn off. Otherwise, you get this huge inflammatory response that'll eat away your arm. So it needs to be very, very well regulated. Well, an autoinflammatory condition is like throwing a wrench in that system. So, like for example, the cut on the arm is the trigger. In autoinflammatory disease, you have that response throughout the whole body without a trigger. Okay, so that big response happens. You get this big inflammatory response, and then it just turns off. Again, we don't know why. There's no trigger, and we don't know why it turns off. But probably the more common one is familial Mediterranean fever, or the periodic fever syndrome. So you have these kind of like, I'm totally fine. All of a sudden I get this 102-degree fever, Fahrenheit, and then you have joint pain, you have pleuritis and serositis, and they feel very sick, and then for 3 days, and all of a sudden it's gone. So it just turns off. So it's that monkey wrench throwing in, and it's igniting your innate immune system, and then it turns off. So that is driven by something called the inflammasome. So the inflammasome is inside these innate immune cells, and that secretes IL-1. So IL-1 is kind of the big driver for these conditions, the autoinflammatory. The inflammasome is just like literally like a bunch of proteins floating around the innate cells, like neutrophils and macrophages. And when the cell gets triggered, the proteins in the inflammasome like combine, and they form like an actual structure. It's like the Transformers, the Constructicons, like all building themselves inside the cell. So when certain things trigger, like a bacteria, it triggers the cell. The feelers on the outside are called the toll-like receptors, feeling outside the cell, looking for anything foreign. And that bacteria triggers that toll-like receptor to alert the inflammasome proteins in the cell. And then all of a sudden the inflammasome proteins come together, and they build this actual structure. And that actually eventually releases something called interleukin-1. And that interleukin-1 is that major inflammatory driver of the autoinflammatory diseases. So familial Mediterranean fever is one of those big drivers. Is one of those diseases. There's adult onset stills, there's a cryopyrin-associated periodic syndrome. There's a laundry list of these conditions. The familial Mediterranean fever is probably the more common. So importantly, back to my point, in certain populations, the carrier frequency of familial Mediterranean fever, meaning someone has one of the copies of the mutation, is 10%. So that's super high. So people of Jewish ancestry or Armenian ancestry, for example, can have carrier frequencies in the general population of 10% of having one of the copies of, and then there's a lot of different mutations for it. So in contrast, to give you an idea of how high that is, like in the West, the most common genetic disease is cystic fibrosis, and the carrier frequency in Caucasians is 4%. So 4%, that's the most common genetic disease in Caucasians, I think, on the West. So in contrast, we have 10% with familial Mediterranean fever with that in certain populations. So you realize why when you realize that Yersinia pestis, the causative organism of the plague, the reason it was so deadly, or one of the reasons, is what it did was when it invaded, it turned off the human's inflammasome. So it went in and had this protein that actually goes in and cuts a knife when it binds to the inflammasome. So you couldn't secrete IL-1, you couldn't have this major inflammatory response to the Yersinia pestis and kill it. So the Yersinia pestis acted by actually turning off that inflammasome. So when you recognize that familial Mediterranean fever, if you have a copy of this mutation, your inflammasome is different. Your inflammasome reacts not inappropriately. So there's some structurally changes that happen in your inflammasome, and those changes probably wouldn't allow your Yersinia pestis to recognize it as an inflammasome and turn it off. So having that copy of the mutation from Mediterranean fever had a huge impact in protecting a population against Yersinia pestis, which is totally wiped parts of Europe during the 1340s. So we have some pretty interesting evidence of how major pathogens have had a huge impact on our immune systems throughout time, but also probably leading to our autoimmune diseases, right? Where we have this immune system that's primed to fight off some pretty virulent bad guys back in the day, that even now with COVID, right? So we have these diseases that can be very, very bad, and our immune systems evolved to handle that for the most part, except now we can overshoot and we get probably autoimmune disease. We don't have a nice story that for all of our diseases yet, but I think we'll figure it out eventually.
It's super interesting. I'd never really thought about how exposure to a catastrophe like the plague could lead to an increase in autoimmune conditions. I guess my question is, if you think in the future there will be more autoimmune conditions as a result of exposure to novel pathogens, or alternatively, I guess another way to think about it is, it seems like there have been more discoveries of autoimmune, like even relatively rare autoimmune conditions. Like there's one I was told about by a colleague, VEXAS Syndrome, which is this this bone marrow mutation that leads to an autoimmune vasculitis, very rare. And do you think in the future there will be more newly discovered autoimmune disorders, either as a result of just more discovery or exposure to more pathogens? What are your
it's a great question. So VEXAS actually is an autoinflammatory condition. So it's actually labeled as an autoinflammatory. So it's really interesting. So that is
can't believe you made that mistake, Mitch.
Unbelievable. You do any homework for this episode?
Come on.
So that's a great question. So VEXAS is a somatic mutation. So it's a mutation that occurs in life. You're not born with the gene. So that just it's almost like rheumatologist's example of cancer, right? So it's just like a random mutation that triggers this major inflammatory. That's why people are most primarily in their 60s, 70s, and 80s who get it. But so I don't think that would be driven by natural selection. But in other conditions, I think, but that's a great question. I think the disease would have to kill, all ages, right? And not just older people, but also probably not be bacteria, because unless there's a super resistant bacteria, because the big difference now is we have antibiotics, right? So we're not going, back then you survived just based on your immune system. You had no idea how it even transmitted. So it was just based on how your immune system evolved. So there probably won't be that selection again from a bacteria. Hopefully, hopefully there won't be that big of a selection again. Hopefully we have a bigger armament. A virus in 1918 could do it, right? Because 1918 killed younger people as well. But I don't, and 1918 may have something to do with certain infections, but I don't think it's known yet how 1918 impacted our immune system. But we know there's interesting changes in toll-like receptors in patients very poorly to influenza versus who don't. But I don't, to my knowledge, is not linked to certain autoimmune diseases, but I think that I'm sure 1918 had a huge impact on the population. Probably 1918 is also during the World War One, so there's a massive amount of death happening globally all the time. So it really it's pretty hard to tease out the impact of certain infections. But it's a great question. I don't think they're gonna, from a bacterial standpoint, probably won't have that selection pressure again because of antimicrobials for the most part. And if a virus does it, it's going to have to, kill indiscriminately, like the 1918 influenza did.
So, what is your favorite rheumatologic disease?
Oh, my favorite. Good question. So what got me interested in rheumatology is vasculitis. I think it's a very strange disease, and it's so dramatic. So you have small vessel vasculitis, but for example, like is ANCA vasculitis is one we think about mostly with granulomatosis polyangiitis or microscopic polyangiitis. And you have the immune system particularly invading vessel walls, okay, causing inflammation of the vessel walls, which can cause weakening of the vessels and cause aneurysms, or it can cause occlusions of the vessels. And it can do such strange things. So patients like normal on Monday, and then Wednesday they're intubated in the ICU, and their lungs are full of blood because all that inflammation of the blood vessels is causing kind of the vessel walls to be kind of weak, and also it's what's called the capillaritis. So the blood vessels kind of start oozing out all the blood, and like in the lungs it goes out into the alveoli, and the alveoli start filling up with blood, and the patient starts coughing up blood, and then they go to the ER, and understandably the ER says, "Oh, it looks like they're probably having pneumonia, right? Because that's probably more common than small vessel vasculitis." So they treat them with broad spectrum antibiotics, and they don't get better. They're admitted, they're watched, and someone starts recognizing their creatinine is going up a bit, But in the hospital, you can all attest to, people with pneumonia often have a rise in creatinine because they have an acute kidney injury on top of, they say, "Oh, sorry, I got hypotensive," when they're getting a little septic. So they have AKI, but no one recognizes. The big thing to recognize is that they have blood in the urine. So that's the big clue to this disease occurring. So people have, there's nothing on X-ray or CT scan that's going to say, "Oh, this is vasculitis," right? So it could look like pneumonia, it could look like any infection from a CT scan of the chest. Lots of things can cause hemoptysis. But if you have hemoptysis plus you have AKI, but you have blood in the urine, which people often miss, that's the big clue. Blood in the urine is showing probably evidence of active glomerulonephritis. So the trick to that is as long as they don't have a Foley in, because the Foley will cause blood, right, in the urine, and as long as it's not a younger female who's menstruating, because that'll also cause blood. So the way to figure that out is to spin the urine. So you look at spin the urine and look and see, once you spin it, and it gets like, and you pull up the tube. Usually if you spin urine down, someone who doesn't have this, you spin the urine down for 5 minutes, and you look at the tube of urine, and it still looks clear. People with glomerulonephritis are quote unquote active sediment. You spin the urine down and you pull it up after 5 minutes, like this big granule at the bottom of like a dirt at the bottom. And then you pour out the urine and then take a what's the word for it? Dipper thing. And then you suck up that granule and drop it on the microscope slide. And then that's when you start seeing, you can see a whole lot of red blood cells, but then you see them kind of in these tube formations called red blood cell casts. And that's the aha moment. This is actually active glomerulonephritis. And then you put it together with the lungs. So it's probably, it's called pulmonary renal syndrome. So a couple things can do that. So ANCA vasculitis can do it. And there's like other diseases like Goodpasture's can do it. But it really kind of helps differential. The other thing about it is like when they're in the ICU and they get bronched and they see it's overflowing with blood, they wash it out, they suck up the blood, and all of a sudden they look back in, there's still blood forming. That's consistent with diffuse alveolar hemorrhage. It narrows the diagnosis pretty quickly. That it could be an infection, but that they usually check an ANCA at that point whenever there's like clear evidence of just overwhelming blood in the lungs. So then that that picture of the diffuse alveolar hemorrhage plus the glomerulonephritis is very much consistent with vasculitis, and that's typically when the patients get treated with high-dose steroids, even if you don't have the blood work yet showing ANCA positivity. So you see that patient intubated in the ICU, may or may not go on dialysis. They get treated, and these patients often do very, very well. And then once the diagnosis is made, so you can like see these people on death's door, and then a few weeks later they're in the outpatient clinic, and so it's really incredible. And so it's now that our understanding of this disease is so kind of minute. We're starting to understand like what's happening at the complement level. So we're actually able to target very specific parts of the complement that could really halt this disease rapidly and really decrease our need for corticoids. So it's a lot of open doors opening for recognizing the disease much better than we used to, but now treating it much better than we used to. And we're starting to get a hint of where rheumatology is going, or we're the butt of the joke of rheumatologists to just throw steroids at everything, which is partially true. But but now we're starting to see that we're starting to understand these diseases well enough where we could actually limit to maybe eliminate the need for steroids for a variety of diseases in the future. So it's pretty exciting where the field's going from that standpoint. My favorite mimic, though, is endocarditis. So endocarditis is like the disease that can kind of look like anything from a rheumatologist perspective. If you PubMed endocarditis plus something from rheumatology, there's probably gonna be case reports of it. Polymyalgia rheumatica, rheumatoid arthritis, especially vasculitis. It could do a lot of what vasculitis looks like. The thing about endocarditis that makes it pretty unique is that it's extremely immunogenic. So if you test people with active infective endocarditis, they're often positive ANA. They have tons of positive lupus serologies, often positive ANCA. They might have a rheumatoid factor positivity. So if someone's coming in with vague symptoms, that subacute endocarditis can be kind of vague, they may get these antibodies checked and say, oh my God, the patient has lupus, right? And they get sent to a rheumatologist because they have all these antibodies. So there's something special about endocarditis that makes it very, very immunogenic compared to other diseases. And so it could trick a lot of people. So that's what I have as on my radar, endocarditis, like I'm always watching for it. It's also pretty cheap to order blood cultures. So I whenever there's something slightly off, I order blood cultures on patients because endocarditis can be very, very tricky.
So I wanted to change topics slightly to talk about your podcast. How did you get started with the Healio Rheuminations podcast?
Yeah, so I was so this is I don't know how many years ago. So this is like 6 years ago. And long story short, as I started getting older, my metabolism started nosediving and I had to start doing cardio, and I hate doing cardio. So I was trying to figure out a way to make cardio more bearable and run on a treadmill. And I was like, oh, that's a good idea. I'll listen to some internal medicine podcasts and try and keep up with internal medicine while I'm doing rheumatology. And I was searching for them. I didn't really find that many. Again, this was already 8 years ago. And that was a lot, right? So I was like, this would be kind of a good thing to do to kind of at Cleveland Clinic, I see a lot of pathology. So kind of good opportunity to kind of talk about pathology and kind of delve into some history and learn how things work and where the disease come from. So I was just complaining to the right people. So I was talking to one of my mentors, Dr. Lenny Calabrese. And I was like, I really want to do a podcast. He said, oh, you want to do a podcast? Okay. And like he sent out some emails. And long story short, Healio, one of the rheumatology journals, said, hey, we want to do a podcast too. So it's like it just worked out, and they sent me all the equipment for it, and I started recording. So I just did a couple. I think I did the history of glucocorticoids, and I did like some stuff on biosimilars, and I started digging into the history, and people seemed to respond well to the history. So I kind of like one of the big things about rheumatology and understanding medicine in general is just figuring out where we come from, like how knowledge has been kind of obtained. And I think a good example of this is gout, right? So gout's like a disease that people kind of blow like, oh, it's just gout, they'll be fine. And we don't really keep in mind that gout's like probably the most painful disease we have. It's unbelievably painful. But we also know a lot about it compared to a lot of other diseases, like how it works. For example, the inflammasome, which I'm sure you all love hearing about now, is actually involved in gout as well. Where I said the inflammasome gets triggered, and again, against like in familial Mediterranean fever, and so it's unknown trigger in familial Mediterranean fever. Well, in gout, it's a known trigger. It's uric acid. Uric acid actually triggers the inflammasome, so it's IL-1 driven. So there's a big spike in IL-1 where you get lots of pain. So I was like, where do we like? It's such a fundamental knowledge that uric acid crystals cause gout, and we treat with steroids. I was like, where did that knowledge come from? So it actually So we learned about uric acid in the 1800s, and this guy named Dr. Gout kind of put together, once you can start measuring uric acid, he used to measure by a string test where you take serum and dip a string into it and see how much crystallized to kind of get an idea of how much uric acid was in a person, which is crazy. But he's the first person to say, there's probably some association with uric acid levels and gout in these patients who have these big tophi. Back in the day, gout wasn't that common, right? Because it was like people who had a lot of food, for example, got gout. Now a lot of people have a lot of food. So there's a lot more like, what the heck is this disease? It's very strange. So it wasn't until 1962 that we got polarized microscopes and actually able to, someone from University of Pennsylvania looked under polarized microscope and saw actual crystals and said, oh, it's actually a crystal disease. They figured out, they got the sample and they gave it uricase, which breaks up uric acid, and then looked under the microscope after the uricase and the crystals weren't there anymore and said, oh, this is uric crystal, this is crystals, uric acid crystals causing gout. So then someone said, well, you know what? this is kind of the great story. So you know what? We recognize that people who have acute gout flares have uric acid crystals, but maybe they're a byproduct. They're not actually causing the inflammation. So how do we test to see if the uric acid crystals themselves cause the inflammation? So how do you do that? Well, you get a fellow, this is a rheumatologist, again, at the University of Pennsylvania, and says, how about this? We're going to go on rounds today and do our thing. This is a true story. But we're going to get this uric acid in a syringe, and we're going to inject our right knee with the uric acid. He's like, and then, we're going to see if the knees respond and have inflame. And then, so he gave it to himself, who was attending, and then his fellow, he injected his right knee as well, and the left knee was the control knee. And the plan was to go about their day. The plan was to go about their day and like round. And they actually said, and if we have a gout flare, we will not treat it because we want to see how the experiment goes and see if it lasts as long as a normal gout flare. So within an hour of injecting their knee with gout, they were on the floor. They were like the floor. They said they were lying prostrate on the floor, like in such incredible pain with their giant swollen. They couldn't move, and they're begging their colleagues to give them steroids. so they they did not make it around that day, around in the hospital because they were in such pain. And B, they did not finish the study because they begged for steroids and got steroids calmed down because it's so incredibly painful. So that's the story of how we figured out that uric acid was the actual trigger to the gout. Was these two guys like, oh, I wonder what would happen if we injected it in our knee. So that's pretty cool, right? So gout all of a sudden, oh, that's a pretty interesting story. Like how like very common knowledge, like that we take for granted, where it comes from, is from some unbelievable pain in someone's knee and some gumption to do it while you're on around. To do that study. So now we know a whole lot more about gout. And I think I appreciate gout better, learning all the work people did back in the day to figure it out for us.
That's an amazing story. Self-experimentation is much rarer these days.
It is much rarer these days. Absolutely.
One of your podcasts on, I think it was the glucocorticoid episode, one of the reasons I really appreciate it is that it's like you just said, it's hard. It's easy to take for granted all of the gains that we've made. And it wasn't that long ago where we didn't even know what the adrenal gland did. Like, it's such an important part of the body. And yeah, it had been chopped up and examined by anatomists, and they knew if they took it out of animals or if it was all like weirdly shrunken in during autopsies that it was important, but they didn't know what it did. It's only in the last like 120 years, 130 years that we actually figured out, oh yeah, this is what happens in this little thing. And throughout all of human history, when they saw the adrenal gland, they were just like, oh yeah, that's kind of important, but we don't know what it does.
Yeah, exactly. And that was an incredible experiment, as you alluded to. They had like dogs getting their adrenal glands cut out and then dying. Like, oh, it sounds like it's pretty important, whatever it's making, and it took a long time. And another interesting thing about the steroids, once they started figuring out like they can actually like kind of take them out and isolate them from adrenal glands, like one of the big pushes and being able to do that was World War II. And there was a rumor going around that Nazi they weren't jets, airplane fighters were taking steroids to allow them to see further and like be able to handle high altitudes. So like be able to go up and handle the high altitudes better than like people not on steroids. It was false. It didn't actually happen. But the steroid was pronounced enough that like the US started pouring lots of money into it. So the three priorities from a medical standpoint in World War II were number one was steroids, be able to figure out how to get them, like actually extracted from adrenal glands or synthesize them. And B was malaria pills. And 3 was penicillin. So penicillin was number 3, and steroids was number 1, which is unbelievable. But because also that's another aside. So we got the reason we have Plaquenil is because of that as well. The Plaquenil came from Plaquenil, which we use so ubiquitously in rheumatology, that we use in lupus, also comes from World War II in that similar strategy, because they were sending all the people. You might say, why are we using an anti-malarial medication in lupus? Or like, how on earth did you think that was going to work in autoimmune diseases? Is because they're using it for malaria, they're prophylaxis, right? So the cinchona tree, where the bark from it is where you get the colchicine, not colchicine, chloroquine, basically from the bark. It was built from trees, taken from trees in Java, in Indonesia, and then the company who owned the islands were in Denmark. Have the people, all like the anti-malarial pills were in Java or Denmark. So in World War II, Japan took Java, and then always obviously Denmark got taken by Germany. So no one had access to anti-malarial medications. So when the US got involved, they're sending all of their troops to the South Pacific. Like, oh my God, malaria is going to be a massive disaster. We have all of our people die of malaria, and we can't get synthetic chloroquine. So someone was making synthetic at that point. It's called Mepicrine, and it sort of worked pretty well, but they couldn't use the natural stuff. So they started giving Mepicrine to all their soldiers to prophylax against malaria. It caused their skin to turn yellow, so it wasn't great, but it was better than dying of malaria. So most of the soldiers took it, and what happened was, upon return after World War II, certain soldiers kept asking to take the Mepicrine. And like, why do you still want to be on this drug? And all those soldiers either had lupus or rheumatoid arthritis, because for the first time, those people with lupus or rheumatoid started feeling better, and they were on the Mepicrine, and they associated the Mepicrine with that. So the first study looked at in the 1940s, right after World War II, Mepicrine and lupus, and it actually worked. And that's when the drug evolved to chloroquine, and then you put that nice little hydroxy group, the OH group, onto chloroquine. You get hydroxychloroquine, which is Plaquenil, what we use now, and that's been shown over and over again to be extremely effective in lupus, especially. So that's how we got an anti-malaria in World War II, that's to use in a variety of autoimmune diseases, just because of using it is total accident. I don't know if anyone ever figured out to give malaria medications to patients with lupus, for example. But again, back to World War II.
Another quick aside is that I think that they figured out that lithium worked for bipolar disorders. They originally used it for gout, and they were giving it to a bunch of people with gout, and they noticed that it happened to decrease manic episodes in people who were getting
I didn't know that. Oh, that's a good fact.
Yeah.
All right.
Yeah. All right. Now a couple of controversial questions. What are your thoughts on fibromyalgia?
Oh, good question. So here's an example. So in when I was in medical school, which wasn't that long ago, there's this like a whole bunch of people saying, is it a real disease? Is it not a real disease? There's a lot of controversy about it. And I think that's kind of where it gets its bad name from. Was this controversy, a lot of physicians not really recognizing it as a disease entity. Again, the reason fibromyalgia has that controversy is because, you had these patients complaining of symptoms from head to toe, and having, every symptom under the sun, and then having all their labs be totally normal. And the imaging is totally normal. And people are like, oh, there's nothing wrong with you. It's all in your head, get out of here. So people weren't listened to for decades, basically. And then I think what happened, I don't know the story that well, but I think that what happened was we started getting better technology. Actually, we'll get functional MRIs, for example, that actually show imaging changes in patients suffering from fibromyalgia compared to people not with fibromyalgia. We're able to see like cerebrospinal fluid studies that maybe show some protein alterations in patients suffering from fibromyalgia versus people not suffering from fibromyalgia. So we start getting glimmers of hints that there's actually something going on. So we start developing hypotheses of what's happening. And it probably, I think of it as kind of a brain-body disconnect where the brain is interpreting signals incorrectly. So if touch here on my forearm, the signal for touch goes from the forearm to the brain registers touch. In contrast, someone with fibromyalgia, if you touch the forearm, everything's fine on the forearm, but that signal for touch goes from the arm all the way to the brain, and the brain misreads that signal as pain. The problem with it is there's not only touch, the body and brain are constantly communicating with one another. You know where your arms are, you know where your legs are all the time. You think all those signals are getting to the brain and getting misread, and you get this kind of diffuse ache throughout the body. People describe it as kind of a deep bone ache or like a flu-like illness all the time. Then there's the cognitive changes that come with it that we do not understand. And I'm hoping long COVID starts giving us some clues of what's happening to the brain in patients with fibromyalgia, where you get cognitive slowing, you get severe fatigue, you get concentration difficulties, you get something called exhaustibility, where if you overdo it, you feel totally wiped out for 3 days. So it has a kind of a laundry list of things that are very, very consistent in patients suffering from it. But I think it's undoubtedly a real entity. I just don't think we understand it very well. And I think long COVID is sort of bringing it to light that this is something people have been suffering with similarly for decades that everyone kind of ignored for a long, long time. So I think in that we still have we call it the F word, the fibromyalgia word, where it's people have this like kind of, oh, it's not fibro. Don't tell me it's fibromyalgia. It's like a wastebasket diagnosis. I mean, you don't know what's going on everyone since it's fibromyalgia. I don't think it's true. I think this is fairly common, and a lot of people that have underlying pathology plus fibromyalgia. So I think that we've done a disservice to people for a long time because of just the disagreement of it. But I think it's clearly an entity. We just don't understand it very well. And we also don't know who takes care of them. You know, it's not an autoimmune disease. It's not, we don't really know what it is. So they're kind of in this gray zone of healthcare, which is a very frustrating place to be.
Can rheumatoid arthritis be prevented?
Oh, yeah, that's a great question. I think right now is no. The answer is no. I hope so in the future it will be prevented. That kind of goes to the fact that you might be asking, how would we ever prove that? We can sort of prove that because a lot of these antibody markers for diseases like rheumatoid factor or anti-CCP, which are associated, are often present years before a disease develops. Lupus, for example, like the ANA positivity, it's like, and the lupus serologies like Prometin, RNP, Smith, you know, all of our favorite autoimmune antibodies are present for like 10 years before the disease develops. So theoretically, you can kind of say, oh, well, let's kind of measure everyone's CCP who's totally healthy, and if it's really high, and say, okay, that patient might get rheumatoid arthritis in 2 years. So what if you treat them early, and see if they get rheumatoid arthritis in 2 years and compare it? So you have to have a huge population to do that, right? To really kind of compare that over time. And the studies that have been done, I think with Plaquenil and rituximab have been kind of, I think, underwhelming. I haven't looked at them that clearly. So the answer is, because you have to beg the question of, do these patients have rheumatoid? Do they have rheumatoid? They just didn't had just minimal symptoms. It's hard to say, do they truly have no disease? You have to do imaging on their hands. If there's synovial biopsies, true, there's no inflammation at all to really say these patients don't have rheumatoid arthritis. So I think that I think it's a really, really difficult question to answer. I think that these patients are probably even the patients like didn't get the disease 2 years later because they're on Plaquenil. What happens when you take them off Plaquenil? Is it actually didn't get it, or they just delayed it? You know, there's too many what ifs, and it's going to take a long time to sort that out. So the answer is I don't know. You know, patients ask me this every day: can I prevent this with diet and exercise? And the answer is I don't know. So I think it's a really important, honest answer, because if you Google it, there's all sorts of cures for rheumatoid arthritis online, right, with all sorts of vegetables and things like that. But think of it: you have a fairly rare disease, 1% of the population, and how would you do a trial to prove that? You say, okay, we'll get 100 people with rheumatoid, and you guys all eat this diet for the next 2 years. This 100 people, you all eat this diet for the next 2 years. The other 100 people, you all eat this diet for the next two years, and we'll see who does better. You have to control for medications that they're on. There's a whole lot of different medications for rheumatoid arthritis, but then you also have to make sure those patients did that diet, and 80% of them would throw the diet out the window after the second day. So long story I don't know if we'll ever know if there's certain things you do to prevent rheumatoid arthritis or treat it without medications, because there's from nutritional studies are just exceedingly hard to do. We have to have a lot of patients actually doing the study to actually really being careful with the diet. It's really true. I think diet probably is important, but I just don't know the answer of what to diet is best to do. We don't know the answer to that.
Adam, thank you so much for joining us on the External Medicine podcast. Obviously, people can find your podcast, Healio Rheuminations. Aside from looking up that podcast, anywhere else you would have them find you on the internet?
Oh yeah, a Twitter account, Adam J. Brown, MD. And I have a online quiz platform for if you want to test your rheumatology medal called Rheumin Boards. So if you just Google Rheumin Boards, you can get some. Usually, all the answers have jokes in them. It's not a very sterile quiz platform. It's kind of a lighthearted, but you'll learn something. Because I think rheumatology is kind of a very opaque profession. So my goal is to make it fun, and you'll hopefully have a laugh.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution. If you'd like to support us, subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.